Welcome, everybody, to our third Odyssey Europe community call already. Very excited about today's topic, which is something that really has been keeping me busy this year, and well, really excited to hear about what the speakers have to say today. Yeah, so let us get started. We will be doing our regular things today, talking about a few publications. We have some node news to share with you. We will highlight a few projects regarding the patient-reported outcomes. And the schedule is quite clearing up towards the end of the year, but we'll look at that as well. Just for any of you that are there today, if you are involved in a project or initiative that you would like to talk about during this community call, reach out to me and we will see when we can fit it in the schedule. All right, so the first thing that we are going to do are a quick round of the publications that have come out in the last month since our last meeting. If you are the author of one of these publications and you would like to very briefly tell us a little bit more about what was in the article, then feel free to pitch in while I am running through them. So the first one that came out is a semantic driven for cohort data harmonization into OMOP CDM schema by Raquel Paradina. And the second one was by Somaya Abedian, integrating Garmin wearable data into Fire-based health system for improved interoperability. Then we have an article coming out from the Pioneer Consortium, Observational Health Data Analysis of the Cardiovascular Adverse Events of Systemic Treatment in Patients with Metastatic Hormone-Sensitive Prostate Cancer and Big Data Analytics using the Pioneer platform. By Pawel Rajwa, big group of authors there. Next one, another Darwin study, secular trends in the use of valproate-containing medicines in women of childbearing age in Europe, a multinational Darwin EU network study by Lucia Bellas. And then one coming out of Israel from Nadav Rapaport, Kinneret, Israel's largest hospital network transformed into the OMOP CDM for collaborative research. Wondering if anybody from that team was on the call, because that seems like a very exciting initiative. Nobody there. Oh, too bad. Next one, current use of common data models in the Nordic countries by Gerard Ompad. Lots of things going on in the Nordic countries. We will come back to that later as well in this call. Probably now when we are on the node news next item. So a bunch of us were in Sweden last week for the Odyssey Sweden Symposium that had their kickoff. It was organized by Christian Högberg, as you can see in the picture on the top right. Different speakers from not just Sweden, but from also many of the national nodes to support this first Odyssey initiative in Sweden. I think it was a very successful day. For me, it was very insightful as well to get to see how the Swedish culture is moving around this whole data standardization process. So that was very good. And one thing I wanted to share with you for sure is the great picture that Jordan Kane had AI generate of the OMEP, the assembly for OMOP in Sweden in IKEA style. I thought that was very fitting for this symposium. So yeah, it was a great day. Lots of very enthusiastic people. I spoke to some afterwards, and they are really looking forward to moving Odyssey forward in Sweden because they all feel they've been, behind, and they are now trying to really get up to speed. And I'm expecting big things now to come out of there. So looking forward to that. Yeah, and the next one coming from the Greek node, which I thought was very exciting. Pantelis shared this with us, that OMOP will be adopted for the health monitoring project in Greece, and the aim of that project is to develop an ICT system for epidemiological surveillance of Greece. based on National Health Data Warehouse, and it's led by IDICA. And it is the first time that an OMOP CDM is actively investigated from a national data infrastructure in Greece. And Pantelis thinks this is a very promising development for our community, and I very much second that. Would be nice if we get some more surveillance up and running. Okay, and then some slides from the Odyssey Belgium team who have a big event today, so they were not able to join us. First things first, the report of the Odyssey Europe Symposium, which was already a little while ago, is now officially available. So it's a nice summary of what was going on that you can read during the weekend or maybe over your Christmas holidays when you've got nothing else to do, to have a nice little flashback to that great symposium. The other thing that they would like to share is that they have an all actors meet, an online winter event on Monday, December 15th. That is online, so anybody can join who is interested. They will be talking about their highlights for 2025, giving us some updates on the oncology work group and the Belgian vocabularies, spotlighting on HTA and health data Belgium, the Belinda Network, VIDO, and the Realm project, and having a little peek into what they are going to do in the upcoming year. And the last thing they wanted to share is that Lisbeth Peters has a new podcast out where she is has interviewed Patrick Ryan. So that is out for any of you who want to listen to that. Here is the code. So also another thing to do this evening or on the weekend, or if you've got one of those procrastination moments, right? So that's coming out of Belgium. Then the next one, Node news from Austria. Adnan, you are on the call. Would you like to share this yourself?
Yeah, thank you very much. Yeah, as you said, we had also our kickoff meeting last Monday, and we think it was a success. We had more than 13 participants from different institutions, universities, SMEs, and also from the Ministry of Health and ELGA. ELGA is the Austrian National Electronic Health Record System, the agency which manages this. We've been invited also to present our work at the Interoperability Forum. This is a forum, this is a long-running tradition actually in Austria. We have this meeting every year, and it's the meeting point actually for stakeholders who is working in interoperability standards, FHIR, HL7, federated analysis as well. And yeah, we're going to be there as a node, which is really great news. And also we planned within the node to dedicate a session at the D-Health conference, which would be in Vienna, in May in Vienna, exactly also especially for Odyssey and OMOP activities. Yeah, so we also invite everyone here also in Odyssey Europe also to join us in this great conference that would be held in Vienna in May next year. That's it.
Great, thanks very much. I was just in Glasgow these last couple of days at the ISPOR conference, met some people from Austria, and I pitched your node there. So I'm hoping that that more people will be joining your node, and still finding a good excuse to come to Vienna in May. So thanks very much for sharing.
You should.
All right. So during the last meeting, I had a slide up with all the projects in Europe that were involved somehow with Odyssey or with the OMOP CDM. And I think I had about 3 projects on the slide. So I did a shout out to the community and say, please let us know if you are using OMOP in your projects. And you have responded, because I've now got a really ugly looking slide with very many logos on it. But I'm very excited to see that this is filling up. I asked AI to make me a nice slide with a beautiful layout, and it just crammed all the logos in one corner. So I decided to do it myself, and this is what I ended up with. No, so I'm very happy to see that there's quite a big number of projects. I am sure that this is not all yet, and that there are more, but it's good to see that we are filling this up. So if you are involved in any one of these projects, and want to be on the call, reach out. If you are involved in a project that's not yet on this slide, then please let us know, because we would really like to get a full overview of everybody that's using the OMOP CDM and the Odyssey tooling in the European project space. So please share that with us. Now, up next, from 3 different projects in Europe that are all working on patient-reported outcomes, we have invited 3 speakers that will be sharing some of their experiences with us today. Very excited about that. So our first speaker will be Lisa Hoogendam. She's a PhD candidate in plastic reconstructive and hand surgery at Erasmus MC. And I'm saying PhD candidate, but as a week from now, she will no longer be a candidate, but she will hold her PhD. So we're very excited that she made time to join us today. So Lisa, I'm going to stop sharing because I guess you have some slides or not?
Yeah, definitely. Thank you.
Okay. And then I will let you kick off.
Okay, thank you. Yeah, so I'm going to tell you something about our experience with mapping PROMs to the OMOP CDM. But I first want to go a little bit back and talk about why we should measure PROMs. So I'm working in the field of hand or wrist disorders. So we typically have patients coming in with symptoms, pain, loss of hand function. And we've actually studied what do these patients hope to achieve if they would undergo treatment. And indeed, we see that they all indicate things like improving on pain, performing activities, gaining more ability to work. And of course, these are domains that you can very easily capture with patient-reported outcome measures. And they are also very relevant to evaluate treatment outcomes. For hand and wrist disorders, we have an ICHOM standard set, basically defining what should you measure for your patient. And as you can see over here, everything in red is captured using patient-reported outcome measures. So that's actually quite a lot for our clinical case. The ICHOM standard set also defines when we should measure PROMs. So you can see over here that we have multiple measurements over the timeline before treatment, during treatment, and also treatment evaluation. And we can link that to the actual consultations. So the information can be used by the clinicians to inform decision making. So patient-reported outcome measures capture relevant outcomes for hand and wrist conditions. And we have the standard set that tells us what we should measure at what time point. But of course, the main question is, once you have that in place, your ICHOM standard set and your routine outcome measurements, how to make the transition to the OMOP CDM. So a couple of years ago already, we received an Eden grant to map our ICHOM database to the OMOP CDM. We also got help from ITTM for that. And well, here you see a screenshot of the dashboard of the Eden portal, showing what we have mapped so far. I have to say this is a bit outdated already. We're now looking at 280,000 patients that we plan to map in our next iteration. For the mapping, the strategy that we used was to mostly reuse the existing vocabularies that were out there. Yeah, to use concept IDs basically from any domain when we felt they were applicable. We've tried to avoid creating new tables and see what we could map in the existing structure of CDM version 5.4. And of course, the data that we have is labeled as, well, a patient-filled survey. So what's actually in that ICHOM set is 26 patient-reported outcome measures, a few patient-reported experience measures as well, and we have some data that's being collected by the hand therapists, but also filled out in a survey form format. So that's quite a lot of data to map, and we noticed that we could map them. Well, that some of the surveys in itself existed within the vocabularies, but most of them did not. And especially for the PROMs, we typically get outcomes on scores from 0 to 100, for example. We have total scores, subscale scores. So also within one patient-reported outcome measure, there's a lot of data. This led us to over 1,000 question variables that we wanted to map. And we've mapped them to a little over 500 unique concept IDs. Some of them exist already, but as you know, or notice over here, most of them did not, unfortunately. The concept IDs that existed and that we could reuse were mostly applicable to questionnaires like, our intake questionnaire that measures patient demographics, for example, and the anesthesia questionnaire that relates to, risk assessment, whether a patient can undergo anesthesia, and strength and goniometry surveys. More of the, very specific hand and wrist PROMs like the Michigan Hand Outcome Questionnaire or the Boston Carpal Tunnel Questionnaire were just not available. And in some cases, we were able to map questions by using one-to-many mappings, because the question is asked for both the right hand and the left hand. And then for the answer variables, we had over 5,000 answers, but of course, many very similar. So what we encountered during the mapping is, as sometimes we could find the survey completely. So both the survey name, the questions, and the answers. That was the case for the EQ5D. The only one I have to mention. In other cases, we could find a concept ID that described the survey, but not so much any of the questions or answers that were in there. And that was the case for the Michigan Hand Outcomes Questionnaire. And some of the questions in there could be mapped to promise items. And in some cases, we had to add like qualifier concept IDs to specify whether which hand it concerned. And then for a lot of the questionnaires that we wanted to map, they just were not available at all. For example, for the Boston Carpal Tunnel Questionnaire. For the answers, there were some pre-coordinated pairs available for the EQ5D, for example. That was very nice to reuse. We had answers, many of them on a Likert scale or a graded scale. And as you can see, like for the Michigan Hand Outcomes Questionnaire, for example, those answers are rated on a never to always scale, if you can say that. And for the patient-reported wrist and hand evaluation, patients are asked to score that on a 0 to 10 scale. So we could map that to like a grade 1 on a scale of 1 to 10. To also include the range that we had there. And of course, sometimes the answers could just be used as a standalone concept. To make it a bit more concrete, I hope, I've made a screenshot of the pain subscale from the Michigan Hand Outcomes Questionnaire. And what you can see over here are the questions that we have in Dutch, unfortunately, with basically asking how often did you have pain in your hand or wrists? That can be answered like always to never. Those values are then in our mapping file, where we map them to a grade 1 on a scale of 1 to 5. which is debatable, I think. There are alternative options as well. But then after mapping, well, this is basically what that looked like in our observation table, where we have the concept ID as well as the original value. We actually recently discussed with Laura and Aniek from the HUL project to see what their experiences were as well, and what our combined challenges were and solutions that we've considered. So that's why I've included this very big, ugly table with what the outcomes of that were. And I'll just briefly touch upon a few of them. One of the things that we very often had is that we had questions that were really specific for like the right or the left hand, or included a specific time period. So, for example, did you have pain in your left hand, or basically, please rate the severity of the pain in your left hand on average over the last 7 days. So and we could find concept IDs that matched a part of that question, but typically things like the left hand and in the last 7 days was more difficult to incorporate. And one of the things that is really relevant to us as well as tracking the response rates, because patients are sent out, receive surveys during their treatment pathways. And of course, we hope that each patient always answers each survey that we send out, but well, we all know that's not the case. So we need to know those response rates also to know how confident we feel about any results and any conclusions that we draw from the analysis that follows. So what we're considering at this moment is whether we can explicitly include token status for token-based software like Lime Survey that we use. But of course, there are many alternative options on how to track that that we're also exploring. Yes, so this is not complete yet. It's still somewhat preliminary work, where we're also exploring sometimes what the right direction is. So also really looking forward to the discussion that we have today. So, thank you for the attention.
Yeah, thanks very much, Lisa. Are there any questions right now from the people that are online? I will try to put in a little bit of a discussion at the end, but if there's this very specific question for Lisa, I'm very curious as to the tracking, how if you want to put the tracking into to OMOP. I kind of get it, but oof.
Yeah, so you mean the tracking of the token status?
Yeah.
Yes. So we noticed that in all of our compliance analysis, that's really something that we use, and we have multiple possible statuses based on the survey can be sent out, but it can be that it's still in the window that the patient has to complete it. It can be partially completed, fully completed. So we have, I think, 7 different statuses that for us are relevant to distinguish. But it typically takes quite a lot of information to derive those statuses. So, for example, you need to know if there was an email address available for that patient, or whether the mail did not bounce back or so. So that's why we're thinking if there's a way to include that, then that would make our lives a bit more easy. I think at this moment, we've also decided to just include, I think also of course, all the answered questions, but I think also the non-answered questions. So at this moment, we could calculate to some extent compliance rates based on that. Although, of course, then it's you miss some of the granularity. Like, for example, that's the survey was sent out, but about the email bounced back. And also having all the, well, basically the empty lines is not something we're very happy with. Yeah, so it's very much a work in progress. Yeah, so I hope to come back to that.
Yeah, no, I
Later
can
on.
imagine you want to have the tokens in your analytics as well to filter out people, but that's something fun to think about for the future. Thanks so much for sharing, Lisa. And we will move on to our next speaker. Yeah, our next speaker is Peter Prinsen. He's the head of clinical data science at the Dutch Cancer Registry. Peter is online, but he is hiding out somewhere because he was at a big conference somewhere, I think. So we'll see if we can hear him. Peter, are you there?
I'm here. Can you hear me, Renske?
I can hear you, sure.
Okay, great. Yeah. No, I was at KWF defending a proposal and then I ran over. And but I'm here.
Thanks so much for joining.
Sure. Yeah. Let me share my screen. So I guess I have about 10 minutes or so for the presentation. Yeah. So I think you have to make sure that I keep to the time. So just interrupt me if I'm taking too long. Yeah, so I'm Peter Prinsen. I'm the head of clinical data science at IKNL. We manage the Netherlands Cancer Registry, so we mainly have clinical data. Before this, I was a data scientist here, and I spent 3 years converting our data to OMOP. So we have a lot of our data in OMOP. We do a lot of studies also in Darwin. And we also have a small set of PROMs data through the profiles registry, and those PROMs data are connected to the NCR patients. So we have some patients with both clinical and PROMs data. So I have a couple of disclaimers to start with. So I'm not really an expert on PROMs data. I'm also not really an expert on putting PROMs data in the OMOP CDM. And the last one is my title is EORTC questionnaires in the OMOP CDM. So you may think that I will tell you how that will be done, but I can guarantee that you will have more questions about this after my presentation than now. But I think that's also good because I think this is something we need to discuss in the community, how to add survey questions to the CDM. So I will talk a little bit about EORTC questionnaires because I don't know if everyone is familiar with them. So I'll give a brief introduction. So basically how these questionnaires work, there is a sort of basic questionnaire, the quality of life questionnaire, the QLQC30, which asks 30 basic questions about your quality of life. And you can score them from 1 to 4, except for the last two that you can score from 1 to 7. And then there are these so-called modules that are sort of additions to the quality of life questionnaire, specifically for tumor types, well, also for non-cancer questionnaires, but I'm only interested in cancer questionnaires. And for example, this one is for prostate cancer. So you get prostate cancer patient-specific questions. So there are questions. The QLQC30, you can also calculate scores. So you can score on a bunch of dimensions based on your answers to the questions. So there are functional scales, symptom scales. You do a calculation and you get a score between 0 and 100%. And then lastly, there is also a paper, because of course the question is, what do these scores mean? Where they looked into, okay, when is a score clinically relevant? So for example, if you take something like the pain score, at what threshold could you say, okay, this patient has pain or this patient has no pain? So I won't go into this, but there's a paper about this. But so the scores also sort of have a meaning that's useful for, I think, the patient and the clinician. Now, the way I sort of got involved into putting questionnaires into OMOP is because we were involved in the Pioneer study. It was a big European project on prostate cancer, and they wanted to work on quality of life data as well. And we were only involved as a data partner, so not technically part of the project, but we participated in studies, and we found out, well, it's basically not really possible to put quality of life data in OMOP, let alone do studies. And of course, so I started discussing this with Mieke van Hemelrijk, who's in the EORTC and also in Pioneer. And well, you can have a lot of discussions on what you really want to put in OMOP, right? You can put an observation that the questionnaire was filled out. That could be interesting for some research. Maybe you want to put the questions and the answers in OMOP, maybe the scores. Maybe you want the mapping of the scores to clinical observations in OMOP. Maybe you even want relationships between a filled out questionnaire and the questions and the answers. And over the past year, we had some discussions also in the OMOP community. Also, for example, with Christian Reich, who very uncharacteristically had a very strong opinion on what could we go in and what couldn't go in. But I don't think this is really solved at the moment. There are some concepts in the vocabulary. Well, at the moment there are more, but there were some on the EORTC quality of life questionnaires, but only the QLQ-C30 and only very limited in the OMOP extension vocabulary. So we started a project. Mieke van Hemelrijk started a project on, well, how do we put OMOP EORTC questionnaires in OMOP? And I wanted to make it a bit broader. So I thought, okay, well, first of all, we need a vocabulary, right? And this vocabulary shouldn't necessarily be an OMOP vocabulary. This should be a general vocabulary that EORTC creates that anyone who wants to put that data in any common data model could use. So the project was basically, let's have EORTC create a vocabulary for their questionnaires, have them publish it, then we can use it in OMOP or other data models. And then also, in addition, look at how this could be used in data models and then specifically in OMOP. There were several partners involved. So IKNL was involved. We had some other data partners with data in University of Deusto and Zeeland University Hospital, and Odysseus was involved. And Odysseus was involved to create the vocabulary. And there, sort of the deliverables were, what do we put in the CDM and how do we put it in? And also this sort of vocabulary. So, and I think it basically has two aspects. One is we create a vocabulary so we can put stuff in OMOP. And the second one is we map the scores to something that's clinically relevant, maybe SNOMED concepts or so, with the help of clinical expert clinicians. And we create some kind of, I don't know, manual on, okay, how do you then put the results of the questionnaire in in OMOP, in your OMOP CDM as SNOMED concepts, for example. So, well, the vocabulary was created by the Odysseus team. You've all seen vocabularies. Vlad, Maria, and Sebastian worked very hard on this, so I can't take any credit for this. It has concepts, it has relationships. I won't really go into detail in these 10 minutes about this. You can find the vocabulary in Athena. So it was added, I think, at the beginning of this year. It's now a vocabulary in Athena. It's called the EORTC QLQ, Quality of Life Questionnaire vocabulary. So that's step one. We have concepts in the vocabulary that we can use to put in the PROMs or EORTC PROMs data into your OMOP CDM. That was the easy part. The next part is how do you actually put it in there? And that is actually much more complicated than you may think. So this is a slide that I'm stealing from Vlad. So this is Vlad's opinion, not my opinion, but I agree with what he's saying. So I think there are a lot of issues with adding questionnaires to CDM. And I think one of them is that we have a lot of survey vocabularies and they all ask roughly the same thing. but it's very heterogeneous. It's I can show another slide. Let me just, it's not in my presentation, but just let me just show this one. I think this is UK Biobank has a question on smoking. When did you quit smoking? And that has a bunch of answers that you can choose from. PPI, I'm not sure what that is, but it has a question, when did you quit smoking? So it's the same question, different answers. And Loink has a question, when did you quit smoking? Same question, again, 4 different answers. So heterogeneous vocabularies, you create a lot of standard concepts if you add them all to OMOP. Loink is 11,000, PPI is 2,000, UK Biobank is 4,000, and they violate our vocabulary principles. One, for example, is that for each clinical entity, there is one way the concept is represented, and I will go back to Vlad's slides that he shared with me. Let me just find the one I wanted to show. For example, if you want to add a diagnosis of diabetes to your OMOP CDM, you have, in principle, one choice. The standard concept from SNOMED and the ICD-10 and the ICD-9-CM concepts are non-standard, and they are mapped to this standard concept. So for questionnaires, you sort of want to do the same, but it's more difficult because the questions are not exactly the same. A second problem is that there are no flavors of null, right? So the absence of a question, you may still want to put that in the CDM, but you're not really supposed to do that. Or the absence of an answer to a question. We're not really supposed to put negative information in there. So an observation of no pain. Do we want to put that in the CDM? Not according to our principles, but maybe it is helpful for research. And then we have the timing issue. And the timing issue is that a lot of these questionnaires are not asking, do you have pain now? They ask questions like, did you have pain in the last week or the last month or the last 6 months? Ideally, in OMOP, the time component is in the date time or the start date or the end date of your table and not in the concept. So you don't really want the concept to say, patient had pain in the last 6 months, because that makes it really hard in Atlas to select patients who had an observation of pain in a specific period. So, well, these are all issues. I don't think they are solved. So this is also, I think, a slide to get some discussion started, and I think this will take time to solve. Vlad's solution was to model survey data through non-standard concepts. So that's also why, if you look at this ERTC-QLQ vocabulary, you will see that all the concepts are non-standard. His solution, which is not really a solution that's accepted now as the solution to put data in OMOP or survey data in OMOP CDM, but it's a solution, is to put all these concepts from ERTC vocabularies, UK Biobank vocabularies, ICHOM vocabularies, and so on in the source concept ID column. For example, the observation source concepts ID or the non-existing value source concept ID. So this would mean an extension of the current model. That's where you put this data, and in the end, there will be a standardized concept that's the same for the same question in the actual concept ID. So, for example, if you ask a question like, basically, which people in your family had asthma, and your answer is daughter, you want sort of a standard concept that's family history of explicit context pertaining to daughter, and then a value of asthma, which basically describes this non-standard question. So that was a bit on how to get questionnaires into OMOP. The second part is what I mentioned is, well, we want to create a vocabulary, put that in there, but maybe we also want to interpret the scores somehow. For example, pain, sorry, and put that in the OMOP CDM. Unfortunately, we weren't able to do that in the project because we were unable to get the right clinical input from clinicians to do this. The reason why this is important, because pain maybe is something that's relatively easy to map, although there are probably also subtleties. But when you talk about sleep deprivation, for example, and someone has a hard time sleeping, The question is, does the score, can you map that to insomnia, which may be a really clinical concept, right? It will be a clinical observation that a clinician should do, and that shouldn't be done in a questionnaire. So should it be bad sleep? Should it be sleep deprivation? Something like that. So I think this is solvable, but we didn't get to that in this project yet. So I think in conclusion, we created a vocabulary. So that's step one. They should somehow end up in the OMOP CDM. I don't think we really know how to do that yet. We were planning to do a study. We haven't done that yet. And we were planning to map scores, but we also have not done that yet. So we did some things, but not everything. And that's it.
Thanks very much for sharing that, Peter. Do you have any idea as to the things that you had planned and you didn't do that you guys are still going to go out and do it, or have you just given up?
So I think the mapping of the scores, I think, is something that should be done, but that we sort of given up because I really wanted to create enthusiasm within the EORTC community to create this vocabulary, to publish this vocabulary, to maintain this vocabulary, and also to do this mapping. But that's been really difficult. So I'm glad we were at least able to create the vocabulary. I would like the EORTC to maintain it. I don't think they have the people for that. So that would be my next step. And I think this mapping, I think EORTC should do that because it's their questionnaire. They should have control over this as well as control over the vocabulary. But I don't think they see the importance of that yet. But if we start using their questionnaires, maybe they will.
Yeah,
in OMOP.
I agree with you. We've run into those problems as well, like who's going to maintain it once it's there.
Yep.
So yeah, thanks very much for sharing this, Peter. It's very insightful. In light of time and to see if we can have some discussion in the end, I am going to move on to the next presenter, which is Laura Verbij from Erasmus MC. She's also a PhD candidate and a project manager for international value-based healthcare and very much involved in the H2O project. So Laura, the floor is yours.
Thank you. I'll start sharing. Let's see if this works. I think it works, right? Great. Yeah, so a lot of stuff has already been mentioned, so I'm just going to hopefully run on through. So I'm Laura, and together with Adnan, that's also here, and Renske, we've been involved in the H2O project and our mapping of the patient-reported outcomes to the OMOP CDM. So really, really short on the H2O project. It's an IHI project that started 5 years ago and has ended and been extended for now, and with the aim to improve the quality of care by including these patient-reported outcomes and outcome sets in regular clinical collection. So for now, we have 4 countries, 24 partners in academia and pharma and SMEs, I think. But we are collecting data now in Austria, Germany, the Netherlands, and Spain. And the aim has always been to reuse existing outcome sets, infrastructures, apps, and create visual dashboards and give patients the control over their own outcomes, and so that they can also view it. And for that, I can see that has been a bit weird now, sorry. We have created observatories, so that's where we are now in the H2O project. There's a pan-European observatories, and there's also local observatories that aim to collect the information, all the outcomes data for the country, and also different academia or hospital centers that will allow their data to be collected, or well, the patients that will allow their data to be collected. So for that, the outcomes sets have been made. So for example, what Lisa showed before, I will also show a little bit, but the outcome sets like outcome need to be defined so that you know which outcomes to collect at which time point. Those have been finalized in core outcome sets. Those have also been published for people that are interested. And from that, a pragmatic implementation set was made. So where do we want to start for the different diseases? There are 4 diseases that I did not mention yet, sorry. Diabetes, IBD, lung cancer, and metastatic breast cancer. And those outcomes and that collection of those outcomes and the representation for the patients of those outcomes have been implemented into the different care pathways in the different countries. And so when the data got collected, or was when the implementations were done, we also wanted to utilize the data in a, usable way, which wasn't really possible. And that's where the OMOP common data model came into the view again, and where we have started with the PROMs, the integration of patient-reported outcomes into the OMOP common data model. So where we are now, I've tried to make a figure. I hope this is sort of representing how our implementation has been going up till now. So for the different disease areas, IBD, lung cancer, metastatic breast cancer, and diabetes, I think. Yeah. So for those 4 disease areas, we have a patient agreement where patients sign what they want to share and how they want to share their data. So do they want to share it in an anonymized way or pseudonymized way, and for what? For every patient, the baseline characteristics are collected, and then per disease specific PROs, for example, what Peter just showed, that there are extensions of the EORTC for different disease areas, like the breast cancer 45, for example, are being collected at a 3-month interval. And then you can see that every 6 months, also more clinical outcomes are taken into account, but also the generic PROs for all the different diseases. So an example of one of those generic PROs that is sent out to all the patients is from the PROMs Global 10, where you can see that there's questions, answer scales, patient answers, which all need to be mapped accordingly. And we also wanted to do that semantic, and we can find that a lot of these questionnaires also have domain scores. So domain score in the PRO sense is, for example, quality of life or physical health or mental health. So it's really conceptual domain of how a patient is experiencing their life and disease progression. So we looked at how we could do that. So we had some, so this is our mapping process. We had an initial search in Athena to see if we could reuse existing vocabularies. And then through that, we had a match analysis in duos and teams, and also had a peer review on our findings. And we mapped them as we categorized them as either identical, non-identical, or non-existent, and had quality checking. And so for us, we calculated the PRO responses. If they were reoccurring, we would count them as 1, because we would just use the same concept every single time. So when we finally had concepts, or during that mapping, we actually found some challenges that have already been mentioned. So what we found as well is that we needed an expanding of the concept mapping, because not everything was already into the OMOP CDM. We also had difficulties representing dates. We also had some difficulties where domain concepts or question concepts were really closely related to the clinical concepts that would also be registered and reported and collected. So we would have to differentiate between the data source and, of course, capturing the negative responses. So how we tried to manage that is the expanding concept mapping by reusing already existing concepts, as we did not have time to create our own beautiful vocabulary as Peter has done. We just blatantly misused and reused, just reused the different concepts that were already there. So for example, for one of the questions, we could see that it was actually almost completely similar. So in the last 7 days, what was the severity of your fatigue or tiredness or lack of energy at its worst is semantically identical to how fatigued were you when your fatigue was at its worst in the past 7 days. So we would just reuse concepts within the H2O network to be able to evaluate those questions. And what we found is that actually only the PROMs and the EORTC have spent some time, or someone has spent time mapping their questions and their answers and their connections into the OMOP CDM. So we reused a lot of those concepts, the concepts of those vocabularies. So for representing observation dates, we also found that it was difficult within the temporal aspect that Peter mentioned. So you could see that in this previous question as well. So here it says in the past 7 days, but there's also 3 months and 2 weeks, or etc. So we had to decide on how we would exemplify the actual date, and we decided to fill in the actual answer moment. Since the question already sort of has the temporal aspect, we decided that the fill-in questionnaire date would be the date of the observation, as it would be represented to the physician in that way as well. So that's how we would map it to the OMOP common date model, by adding the that exact date. There were also some concepts in which we actually used a temporal qualifier. So we would qualify the concept as during the last 7 days, for example. I thought that was relevant. So for the differentiating between the data sources, there is, for example, physical health, or how do you experience walking up the stairs. But there's also, of course, clinical concepts that closely relate to that. Specifically for the stairs, there's also this measurement where you have to calculate the time for someone to walk up the stairs. So here we would just add a classification of either patient-reported or clinically reported by using specific concept types and adding those to the observations. And of course, the negative responses, which you've already heard quite sometimes coming back. Although I do agree that they're very, very relevant, because people that are fatigued during some types of treatment pathways and others that are not, we will want to qualify why people do feel fatigued or not, because it is such a complex concept. So I do think it would be really relevant if we could find maybe a unified way for this. The way we approached it now is that we set a value as a concept idea. So we would have, for example, fatigue or something similar, and you could just add a value as concept ID for, and have it no, which sort of negates it. Using the appropriate concept ID for the question and setting the qualifier of no history of would also be possible if it is relevant. But then it would always have to be a certain either condition or diagnosis. So that would be appropriate for that. And approach 3 is just using that inherently negative concept. So for example, no history of malignant tumor breast, where the diagnosis is already included in the concept. Yeah, so that's what we did. We're still working on it, and we're aiming to have a paper submitted at the end of this year, hopefully, fingers crossed. I'm looking very lovingly at Adnan to maybe help me. And maybe some things that we ran into I thought would be nice to mention here. So I do think a lot of people are working on it, but there is not yet one way where we want to that has been decided how it could be implemented, I think. So that could be good, I think. I know that on the international level there is a lot of stuff going on. So it would be nice to keep that in view. Maybe also something that we didn't take into account that I would think would be nice is focus more also on those domain scores, where the domain scores are related. So for example, distress is often disease related, but is also overarching. There are crosswalk scorings, at least that's what they call it in the Netherlands. But for example, there's a website, Rosetta Stone. I always like puns, so I like that one. But there are questionnaire and domain scores where conversions can be made. So that would allow for a lot of different measurements or different questionnaires that have been used, also to be used in larger scale research, since you can actually calculate the scores between them to each other's scores. I hope I'm explaining this correctly. And what we also ran into is that it helps to have this clinical methodological input, because it helps specify more, okay, but how then do we need to actually utilize this, and what is essential and what needs prioritizing and whatnot. So those were our conclusions, I think. Thank you.
Yeah, thanks very much, Laura, also for your insights here. And I'm seeing a lot of similarities between the issues that all three of you are facing, which makes me happy because that that we have similarities that we can work on. I wish we didn't have these issues. One thing I'd like to throw out in the group is what can we do to make this easier? I'm guessing it's tackling all these three problems, but if you were to have to pick one of them, which do we need to tackle first? What's the one that would make life a lot easier for anybody who's going to be using PROMs in OMOP?
So I would take the fourth problem, which is getting together and solving it together, maybe.
That's not a problem, though. That's a challenge. I like that. I
Solution.
like getting together and solving it.
No, so because I think like we are doing, like we're all doing, maybe we're trying to figure this out by ourselves or in smaller groups, and we hope OMOP will Odyssey will solve it for us. But I guess in a way,
Wait,
of course,
no,
we
no,
are
no.
Odyssey.
Exactly.
Yeah. So we have to solve it. Yeah.
Okay, because the second question I kind of have is like, once we've got this in there, I feel we need standard analytics to deal with PROs. And I think that's something that we need to start developing simultaneously, because otherwise we will have put all the, forced all the data in there and then feel, oh, for analytics, it would have probably been better if we would have taken left instead of a right turn there. So I think we need to co-develop these. Do we need to set up a 3-day PROM workshop and see how we can tackle these problems once and for all?
Yeah, Renske, as you were saying that, I was thinking that what I missed from the presentations was the prevailing use case of what's the actual piece of evidence that we're trying to generate from having access to this information. And as I was thinking about like data modeling approaches or analytics approaches, like it's hard for me to even come up with a standardized solution to the space if I don't actually know what the target destination is. Like when Lisa was talking about tracking, it seemed obvious to me that most organizations that are doing prospective data collection need to do tracking, but my strong suspicion is that everybody tracks things differently because it's like an administrative task that it's very organizational dependent. On the flip side, if a whole lot of organizations all had the exact same questionnaire and were capturing stuff in the same information, presumably it's with an aim towards using the answers to those questions for some motivating clinical question. Like we want to show the relationship between quality of life and whatever, some medical intervention, or change in quality of life as a result of something. And it would be really useful if we could align on some of those use cases, because I think that could actually help the working backwards from like, what do we want to do? How are we going to compute it? Back to like, how do we actually model the data? And the other thing that I've also missed was, I don't know in our broader community of all the possible surveys that are out there, which surveys are actually being used across institutions. And so I don't think the solution should be wait till the Odyssey vocabulary magically contains vocabularies to support these questions. I think it's actually that the community needs to identify what questionnaires and surveys are multiple institutions actually using for a motivated use case. And then I think there is a clear path if we know the questionnaire and we know the use case, so we can bridge the gap together.
Yeah, agree there. Ruud, you want to pitch in?
Yeah, I think it's a very good point. So I like the idea of seeing if we can do like a workshop and make some steps. I think in response to Patrick, I think many of the use cases are not so dissimilar to what other Odyssey fields are doing. It's just that in some medical fields, PROMs are really the key outcome for elective treatment, and mortality or survival is or some other dichotomous measure is not. And fortunately, there's a lot of international consensus, things like ICHOM going on to limit. So the space of PROMs is like endless. There was a while that everybody made his own PROM. I think we passed that a little bit, but not fully. But there are some prompts that are like EQ5D, for example, is one that everyone's using. So might be interesting to look for a couple of partners with similar prompts and start doing the whole process and not just the mapping. I like that idea a lot.
I'm going to pitch in here and suggest that we tie that into the Odyssey Europe Symposium in April of next year, when a lot of us will be together. See if we can spend one a day on the weekend or add some days after. We'll see how we can get this logistically done, if we can add that in there when people are already together anyway. Sophia, on your day off, you are here joining us for this. Thank you so much.
Well, it was a very interesting exercise to look at this. No, I just want to say that if we do an exercise like that at some point, it's really important what Peter said, like how we can also engage people who own the PROMs, because we can do stuff on our own, but it can be very disconnected otherwise.
Okay, so we need to find those pioneers that will be that are open to this. Okay, we got some work to do. Aidan.
Sorry. Like I think increasingly as within cancer, definitely PROMs are increasingly important because patients are living longer and there's a need for metrics that aren't progression-free survival and overall survival, but we're looking at time between treatments, but also quality of life in the time between treatments. I know the new ECPDC EU SIP program, which is the patient portal under the UNCAN platform, has PROMs and PREMs as a major guideline under that, and development and standardization of those. So maybe engaging with that community might be useful.
Okay, thanks for that. Guys, looking at the time, I really feel that there's a lot more we could discuss, and I really would like to get into detail, but we're already running late. I think we need to continue this. I will look into see if we can plan something that is convenient for as many of us as possible, and see if we can get as many stakeholders together in one room and solve this, or at least, get ahead on solving it. I won't say solve this once and for all. Thanks very much for those presenting today. For your input. We will be continuing this discussion. I am going to skip the schedule spotlight for today because there was not a lot on it anyway. Thank you all very much for joining. Oh, thanks for the link there, Aidan, as well. Looking forward to seeing you guys next month, December 11th, off the top of my head, where we'll be talking a little bit more about vocabularies in the European space. So thanks for joining us today. Have a good rest of your day and see you all around soon.
Sorry, I think I've just put up the wrong link. I'll fix it. Sorry.
Okay. Thank you.
It's also called EU SIP. There's two programs called EU SIP. I think I put the wrong one up. Sorry.
No worries. Thanks, Aidan.